Okay, I've shared this slide in previous lectures, so I shall not go into it in detail, but I just wanted to highlight that what we take for granted, which is breathing, and the end result of breathing is the oxygen enters our bloodstream in the alveoli, and carbon dioxide gets into the alveoli and then is exhaled out. This whole process involves the interplay of small and medium airway patency, the respiratory pump, so our muscles controlled by the nervous system, and lastly, patency of the upper airway itself. And with this whole complex thing, we can control the acidity in our blood, we can expel excess carbon dioxide, we can take in enough oxygen, and on top of that, we can swallow safely, I can talk, I can sing, I can smell my durian. But many of these processes go wrong in motor neuron disease. For example, the neuromuscular function of the breathing muscles, of the upper airway muscles are affected, and that can lead to like upper airway obstruction, obstructive sleep apnea. It can lead to inadequate breathing, and the result is that the patient's physiology is disturbed. I think all of us are familiar with the type 1 and type 2 respiratory failure, so I won't belabor the point, but I think in our day-to-day practice, sometimes it's as a knee jerk, we see a low SpO2, we put up the oxygen, and we sometimes think that oxygen is harmless. Well, it is harmless, but unnecessary for you and me, unless we have COVID. It is possibly harmful in someone with muscle weakness because it may lead via various mechanisms, increased VQ mismatch, affecting the central respiratory drive to hypercapnia. And therefore, if you're giving oxygen to someone with significantly severe motor neuron disease, you always think of augmenting the breathing as you give the oxygen. So now we come to why any surgical, endoscopic, even some radiologic procedures are risky for MND patients if they need anesthetic or sedation for the process. Okay, so we shall cover the risk due to anesthetic pharmacology, the risk of certain airway interventions, and the risk of the procedures themselves. Okay, so the lay person thinks that anesthesia is just going to sleep, and certain myths actually get perpetuated. Like it is true that if you have IV propofol, when you wake up, you feel very euphoric for some people, and the same may happen if you have fentanyl or morphine, but that doesn't mean that you were sleeping, because actually when we sleep, we go through different sleep phases, and there's a very distinctive sleep architecture. But anesthesia essentially, for at least for the intravenous anesthetics, what it does is that it affects the neural excitation, and it actually knocks out the sleep architecture. So you're rendered unconscious at higher doses rather than you are sleeping. Okay, so there's a distinction there. We don't actually understand how inhalational anesthetics work yet. But again, the common effect is that you're rendered unconscious. So if you put a summated EEG on the forehead and you monitor the brain waves, then we notice that when you are under deep anesthesia, it's as if you are encephalopathic. Your brain actually like shuts down and stops acting. So this anesthetic pharmacological effects affect the breathing drive. So I didn't include the graph here, but typically you have a vertical axis of minute ventilation and a horizontal axis of carbon dioxide partial pressure. And if your normal ventilatory drive is like that means that at this carbon dioxide partial pressure, you have this minute vent. At this level, you have this minute vent. Then with any sedation or anesthesia, this curve is rotated clockwise. So you need a higher level of carbon dioxide to get the same minute ventilation from the body itself. So if my patients decide to like take a lot of fentanyl, or they take a lot of midazolam before they sleep, and they are not on non-invasive ventilation or invasive ventilation, then they run the risk of under breathing during sleep, and the carbon dioxide goes up to 50, 60, or 70, and that could be dangerous. Well, this happens also if you have undergone sedation, and then we need to monitor you until the anesthetic effects wear off, right? It's not immediate. The half-lives of some of these drugs may be fairly prolonged. Anesthetics also affect the upper airway muscles, making them weaker, more discoordinated, and therefore the upper airway patency is lost. So in you and I, when we inhale, actually our vocal cords also open up, and then there's neurological drive to the pharyngeal dilator muscles. So you can imagine if that our diaphragm and intercostal muscles, primarily a diaphragm, is usually preserved. So at light levels of anesthetic and at subclinical doses of muscle paralytics, the diaphragm will function. So it will move, your chest will expand, there will be a negative pleural pressure, but your pharyngeal dilators and vocal cords are not opening. Then what you have is you're sucking here and closing here. And if that happens, then the breathing is not effective. Lastly, of course, if someone already has got muscle weakness, any lingering paralytic agents will lead to weakness and ineffective breathing. Also, it will lead to ineffective swallowing, because swallowing is a very complex process. So we normally will exhale, pause, and when we pause, the vocal cords close, the larynx rise, epiglottis comes down, and then you swallow, and then you exhale again. So if your breathing muscles do not coordinate with the pharyngeal dilators, the vocal cord dilators, or the vocal cord adductor muscles, then the swallowing rhythm may go wrong, and then you may inhale saliva, which is bad, right? So the anesthetic drugs themselves should not be taken lightly. They are dangerous in people with neurological conditions. Now we come to airway intervention. So I think nowadays most anesthesia is done with the laryngeal mask airway. We call it supraglottic airway. So it sits behind the tongue above the vocal cords. Generally, it's very safe, but it may not work if someone already has vocal cord spasm, because it's sitting outside the vocal cords and then you are blowing air or anesthetic gas. And if the vocal cords don't open in time, you don't admit the air in or the anesthetic vapor. Of course, the laryngeal mask itself rarely leads to direct trauma. So I have personally seen 1 or 2 cases of lingual nerve injury due to pressure from the laryngeal mask. I have seen, or rather in my department, we've heard of 1 case of a lingual frenulum injury. So the tongue gets dragged backwards and the frenulum, which is attaching the tongue to the floor of the mouth, is ripped apart and torn. Okay, uvular injury has been described, so that is horrible. So the uvula, instead of a nice little red thing, becomes very, very edematous and enlarged. And lastly, arytenoid injury. So I suppose if you're using a fairly rigid laryngeal mask, an oral gain, and you push very hard, you may dislocate the arytenoid. Intubation itself also causes all these trauma. So vocal cord edema is very common. I think all of you know. But intubation itself, because it goes below the vocal cords, it leads to mucociliary tree dysfunction. So the little hair in the trachea, they cannot do their work of sweeping the phlegm up, because the phlegm reaches the cuff and then the cuff blocks the phlegm from coming up further. Of course, the dry gas that you inhale with the ETT also does havoc to the mucociliary tree. And these will tend to lead to atelectasis following anesthesia. Of course, the careful anesthetist often would put the patient on some degree of PEEP during the surgery, and at the end of surgery, will normally do a recruitment maneuver, but that may or may not be enough to reverse the atelectasis. For any individuals with pre-existing severe vocal cord dysfunction, so for example, then you may not, you can be sure that original vocal cord dysfunction plus all these will make your vocal cord function even worse. So if if I'm someone who you are worried that I may fail non-invasive ventilation and need intubation and or tracheostomy, then any intubation will compound that risk and make it worse. Okay, so I think like most MND patients will come with an advanced care plan that says, I do not want chest compressions, I don't want cardioversion, I don't want intubation. That needs to be discussed before any sedation, because it will be terribly traumatizing for the patient to say bye-bye to their loved one and then receive a dead body, a corpse, at the end of the procedure. And similarly, it is awfully traumatizing, especially to the endoscopy or surgical team who are not prepared for this kind of scenario. So certainly, I think any advanced care discussion should be properly made. And even if you have ACP that says, I don't want this, you may want to consider waiving it for the duration of the peri-procedural period, and then you assure the patient and the family that, okay, we respect your wishes, but if something happens during the procedure, we will resuscitate you, but we will make sure that you are anesthetized so that you are not uncomfortable. We'll bring you to ICU, and then there we will wake you up, assess you, and we'll discuss with you again, and we'll also discuss with the family again. I think that may be reasonable for the psychological health of the survivors, as well as for the health of the team, the surgical and endoscopic or radiology team. Okay, surgery itself, as you know, is trauma. That's why you need anesthesia to protect you from the trauma. So there's pain, there's inflammation. We always tell patients that you will likely survive the first 24, 48 hours of surgery, but whether you will heal depends on your body's reserves. So for example, if someone has motor neuron disease and now has a colorectal cancer, and they are going for a tumor resection with the intestinal anastomosis, joining back the intestines, then you will actually need good healing mechanisms for the intestines to anastomose. And usually anastomotic breakdown happens about day 7 to day 10. So you will be like very nervous for the first 1 to 2 weeks, looking at the patient, wondering whether everything is okay, right? I think if like an MND patient who is sedentary, bedbound, nutrition may or may not be optimal, they will tend to be have a little bit of poorer circulation. They will be more insulin resistant. The fluid status may be a little bit different because with the sedentariness, the fluid distribution is different. So they might be at a higher risk. This is just conjecture. I don't have any evidence to prove that MND patients heal worse than a normal patient, but just conjecture about normal body physiology and the effects of being sedentary. Okay, so then if a patient ends up with a wound infection and abdominal, if you have an anastomotic breakdown, it's disaster, game over. You almost will be assured of a 3 weeks or 1 month or 3 months stay in ICU with a tracheostomy, right? So a motor neuron disease patient with a colorectal cancer and he's on non-invasive ventilation or on nothing, you really want to discuss, do you want to treat the cancer or not, right? If you treat the cancer, you may win. And the chance of surviving may be like 80%, 70%, 80%. But if you're the unlucky 10 or 20% who don't, then are you prepared for a tracheostomy, for a prolonged ICU stay, or do you say, okay, if I get an anastomotic leak after colorectal surgery, I'm going to give up and get full palliative care, withdrawal of life support? So all these needs to be discussed. And then you need to discuss in the context of your medical legal practice. So if you are in the ICU and intubated, are you allowed to extubate the patient if he is not actually actively dying, but you extubate the patient because of a agreed advanced care plan? So the advanced care plan is living with the trachea is not compatible with my wishes or compatible with my family's care capacity. Therefore, if I have an anastomotic breakdown at 1 week, I'm going to extubate and get full palliative care and pass away. Is it compatible with your institution, your country's laws? So I think this needs to be discussed. Abdominal surgery itself is particularly troublesome because the abdominal swelling will lead to splinting of the diaphragm and decreased chest wall compliance. So even if you're on a ventilator, we may have to ventilate harder, you see higher pressures. And in the absence of like gastric and esophageal pressure monitoring, some people may be nervous about setting the ventilator pressure so high. They worry they injure the lung, and therefore it's a tricky thing. Tricky for everybody, more tricky for MND patients because they already have chest wall restriction. Okay, so all anesthetists and intensivists looking after MND patients should read and reread this paper. I won't go into detail here, but this is a prospective case series published by this group of authors, and they basically describe how they extubate these patients with neuromuscular weakness. It is very different from conventional ICU practice. Conventional ICU practice says that every day I turn off your sedation, every day I cut the ventilator down to the minimum, and I observe you for half an hour and see whether you are extubatable, and then if you are, I pull the tube. So that won't work for your neuromuscular patients. Okay, so the approach to neuromuscular patients is that you would have to choose the patients who have got intact bulbar function. So if the bulbar function is not intact, pre-procedure they cannot talk. The chance of successful extubation to non-invasive ventilation is very low. Secondly, you need to clear out the lungs. So any pneumonia, fluid overload, bronchospasm all need to be optimized. They can be on high ventilator settings, but they should be on minimal oxygen supplementation. So in the paper, the authors actually push the patients to room air. And that is very counterintuitive in Singapore. Nobody gives room air in Singapore until we started doing this and people are freaking out. I don't know about Malaysia, I don't know about Indonesia. Okay, so the reason for not using oxygen is that you want to know that the gas exchange, the ventilation perfusion is perfect. And the only thing inhibiting the patient from liberation is the mechanical aspects. So the mechanical aspects will be replaced by non-invasive ventilation, but the gas exchange dimension cannot be replaced by non-invasive ventilation. Okay, so down to room air, you probably want to either ultrasound or do a chest x-ray to show that the lung parenchyma is healthy. And then in these cases, the part of the protocol is to re-expand the lungs aggressively, use cough assist to clear out all the secretions. And the proof that you are okay is the x-ray, the ultrasound, or the low FiO2. Then they actually extubate the patients to continuous non-invasive ventilation. So imagine if you do not have a gastrostomy tube and you extubate the patient to non-invasive ventilation continuously with a nasogastric tube, you are setting yourself up for problems because you will have pressure injuries and so on and so forth. So this is a very different approach to intensive care. After they are extubated non-invasive ventilation, in Singapore, our practice is very paternalistic. We say, okay, today we do 2 hours, 4 hours, 8 hours ventilator free time. But in that paper, they actually allow the patients to dictate and decide how they want to lengthen and increase the ventilator-free intervals. So in that paper, actually, some of the patients actually did well, and then they were able to be weaned to part-time non-invasive ventilation. In fact, a number of them actually weaned off the ventilator within a week. Okay, so but I think in Singapore, Malaysia, and Indonesia will be having to change the inpatient ICU culture tremendously to adopt this practice. So this practice has not been has not been embraced by many normal centers as far as I know. Usually it's only in the centers with neuromuscular disease where they practice this. Okay, so how do I advise my patients? I talk to them and I explain what anesthesia is. And I always ask, okay, if something goes wrong, are you prepared to live with a tracheostomy? Is it compatible with your wishes? And is it compatible with your family's capacity and capabilities? Okay, so if the answer is no, then you may want to say, maybe I don't want the surgery. So if it's elective surgery, so I've given 3 examples here: total knee replacement for knee pain, So if you are still walking and then the knee is hurting, can you use less invasive ways to alleviate the pain? Can you use a knee brace, use walking aids? Maybe in a year or two, you will not be walking anymore, and therefore the knee replacement is irrelevant. If you ask me, I think a knee replacement is not very wise in someone with motor neuron disease that is diagnosed, although I'm not here to judge them. Okay, you will ask, is it safe to do a spinal anesthetic for knee surgery? I think answer is yes. So if these patients come to us, we will always counsel for regional anesthesia if possible. But one of the problems with regional anesthesia is that it can fail. So if let's say you decide to do a subarachnoid block and then there's patchy block and halfway through the surgery is painful, once you have like opened up the joint, you are committed. You cannot say, okay, I will close shop, right? So you will still need to consider using sedation and or even a full general anesthetic. Okay, common for many patients are shoulder pain because their muscles are weak and then they track and then they injure the joints. Do you want to do a rotator cuff repair? This is, I don't know about Malaysia, maybe our anesthetists are very skillful, but in Singapore, we hardly ever do this under pure regional anesthesia. It's always GA, but we may do regional anesthesia for post-operative analgesia. So I would say that this is a lifestyle and sport surgery. It does decrease pain, but the risk is fairly high. And unlike the knee surgery, I can't safely do it under regional anesthesia. So I would strongly discourage rotator cuff repair. If you have gallstones, do you want to do laparoscopic cholecystectomy? So if your gallstones and the gallstone migrates into the intrahepatic duct, you may get hepatobiliary sepsis and may die from that. It's dangerous. So this is potentially life-saving. But that said, a lot of us may walk around with gallstones that we do not know exist. So do you need to do laparoscopic cholecystectomy? So I think these three cases I put up as more frivolous examples of elective surgery. But personally, I've encountered patients who have bleeding colorectal tumors. And do you go ahead with surgery for that? If you don't do surgery, they may pass away. If they don't pass away, they might obstruct later, and that could be painful. So I think each of the scenarios needs to be discussed with, and the patient's wishes, the capabilities of the healthcare team all need to go into the balance, right? And then you must have a backup plan 1, backup plan 2, backup plan 3. What happens if this happens? So naturally, we will be discussing what happens if you end up with a tracheostomy. So nobody wants a trachea unless they absolutely need it. Many of these patients would have said, in the normal scheme of things, I don't want a trachea. But if I'm coming for surgery, let's say I have a colorectal tumor and I feel that I want to try to live 3 more years or 5 more years, then I want to get the tumor out of the way. Then I do the surgery. I must think about what will happen to me if for some reason I end up in intensive care longer, I get intubated, I need a trachea. So the tracheostomy is itself, the risk is low. So we always quote less than 1% risk of serious complications. Serious complication meaning a devastating life-threatening bleed, life-threatening damage to the airway. So these are quite rare. Okay, the main problem with the tracheostomy is that functionally it is likely to decrease the swallowing function. So it's almost universal. And if you or me get a trachea now, we will take a few weeks or months to relearn how to swallow properly and eat properly. Okay, whether you can speak after a trachea or not depends on two things. One is on your prior speech capability. So if the patient already has bowel dysfunction, so they are unlikely to speak well after trachea, but actually it's not too much of a loss because they are already slurring and they're probably using other ways to communicate. Someone with very poor lung capacity, the speech is clear but very soft. Then if you put a trachea, you can borrow air from the ventilator and actually paradoxically, the speech may improve. The most common reason why in Singapore someone with a trachea cannot speak is because doctors, nurses, and therapists are ignorant about how to facilitate speech in tracheostomized ventilated patients. So that's why we've gone on a crusade to teach people how to help ventilated and tracheostomized patients to speak if their body allows them to speak. Okay, so I've covered these two, but the biggest problem with tracheostomy is that it prolongs survival. So in the Singapore, in the Tan Tock Seng case series that we've published, survival from the initiation of non-invasive ventilation, the median duration is about 1.7 years. But the median duration of survival of someone who is initiated on tracheostomy ventilation is about 3.7 years. So it doubles your survival. So survival is a good thing because life is precious, but life with disabling illness is suffering. So it is a precious entity, but it comes with suffering. So are you prepared to take that suffering? I think a lot of us will observe that the patients who feel that they have a reason to live will take the suffering better. So those who live because they love their loved ones, they want to see the son get married, see the grandchildren grow up a bit more, they feel that the spouse will be lonely and they want to accompany the spouse a bit more, they are likely to not be very existentially depressed and want to commit suicide after they get a trachea. You also need certain minimum resources to live well with a trachea and a ventilator. So you need 1 to 2 people round the clock all the time with you. That person could be a family member, loved one. So, if you have a large family, different children, uncles, aunties, nephew, nieces can take turns to help, although not all are well trained, right? Or if you have more money, then you can employ 1 or 2 caregivers or domestic workers. So if you are in a very dicey family situation with no family members and loved ones, then are you sure you want to prolong your survival? Because when family members are counting every cent every month and say, oh, I'm going to debt, I don't have money to pay the bills, then you threaten the family love that happens, that is still in existence. And then if only one spouse or one child is the one looking after you day in, day out, not able to get proper sleep for 3 years, you are testing the mental health as well as the character and virtue of your loved one. And are you sure you want to impose that? Okay, so we often will have to go through this with the patient and family, and there'll be conflict. So you need to be sensitive and sensible in discussing with them. I just briefly recap trachea and speech, trachea and swallow. So trachea is here, and then it leads to a bit of a dead weight. So when we swallow, if all of you put your finger on your Adam's apple and swallow, you notice that the glottis migrates upwards. So when we swallow, what happens is you exhale partially, vocal cords close, glottis goes up, epiglottis comes down. So you have a trachea is dead weight, and this process worsens. Secondly, if you have a trachea and the balloon is cuffed up, it also blocks the upper esophagus, the pharyngoesophagus, and food bolus doesn't go down so easily. Does a trachea protect from aspiration? If you cough up the balloon, what it does is that food or saliva may get trapped here, but over time it may still dribble down. If you have an open tracheostoma, breathing on your own, cough is down, air comes in, air goes out, but when you're inhaling, the pressure in the trachea is actually negative. So if open stoma, there is no cough, the saliva may very well get inhaled during inspiration. Okay, so what you need to do to protect against aspiration is actually that you need to either have a speaking valve or you have a ventilator connected and the cuff is down, cuff is deflated. That way, there will be a positive subglottic pressure, or when you cough, the positive pressure can drive the saliva or the food up out of the windpipe. Okay, so I just show you 2 patients who have got good speech with the trachea and ventilator. Both of them have MND.
How are you feeling? So what did you do? You can walk. Hey everyone, 2020 has been a tough year, especially so for us, the vulnerable.
So both of them have been admitted to ICU because of severe hypercapnia and respiratory acidosis. So they have a type 2 respiratory failure. This gentleman was still quite strong. He could walk and he remained able to sit, to stand, and to walk a few steps for about a year after his trachea. This gentleman was already tetraplegic by the time he went home with the trachea. Okay, but the commonality is that they have intact vocal cord functions and therefore they were able to speak. This gentleman was and still is eating quite a bit. He was eating 100%. Now he's taking a bit more via gastrostomy. This gentleman was tube fed from the word go. Okay, but you will agree with me that these two are atypical motor neuron disease patients. A lot of them will have some degree of slurring, and therefore, after a trachea, they are not likely to be able to speak so well. But they maybe will say a few words like, yes, may still be meaningful to them and still be intelligible to their loved ones. So we don't discount even slurred speech, and we always try to restore audible speech as far as possible. Okay, so what do I tell my MND patients? I say you protect yourself, avoid falls. A lot of them are risk takers, so they want to stand up and walk very fast, but you know, like the bibrachial one, and they cannot hold on to anything because their arms are weak, but they walk fast because they're actually falling forward. Their truncal control is no good. So they stand up, then they like a penguin rushing forward. Very dangerous. So you need to ask them to walk with a helper, invest in a transfer belt with adequate holes for the helpers to hold on to them, and so on and so forth. You need to teach the helpers not to hold the arm, because you hold the arm and they fall, you will dislocate the shoulder, right? Or fracture the humerus. Be careful of head injury. So I've had patients who are sitting in some kind of improvised commode in the shower and then fell and knocked the head against the toilet wall. Okay, if you have a head injury, game over, right? Because about head injuries, I don't have a motor neuron disease patient with head injury, but I had one patient with myotonic dystrophy. He was actually still working. So he was working, earning money. His wife was, both he and his wife are low income and they got a young daughter. And they're also looking after their parents. So he had a head injury, then he had subdural. Subdural was evacuated. Then he subsequently had hydrocephalus. He was in the neuro ICU for like 4 months, in and out of the neuro ICU. So he came in and out each time like 3 weeks, 4 weeks. Before the injury, he was working, he was walking, he was eating, and he was using nocturnal NIV just to control the CO2. His speech was quite clear and intelligible enough for him to work. But now, about a year and a half after his fall, he's tracheostomized. He can lift up his arm on good days just to give us a thumbs up, thumbs down. He can turn himself a little bit in bed with help, but not able to sit up or walk. And therefore, even though his is myotonic dystrophy, it should not progress so fast. The head injury has led to a rapid deterioration in his condition. And now he's awaiting placement in a chronic sick unit, which is like a very high-end nursing home in Singapore. And it's very unfortunate because his wife and daughter are still financially quite needy. So it's not going to be easy for anybody. So avoid trauma, avoid falls. Okay, don't take risks, don't take scooters, bicycles, and so on. It's always good to consider what's important to ourselves, consider and reconsider goals of care, avoid pressure injuries to the skin, because again, these sometimes can be treated conservatively, but sometimes they may need more radical treatments, otherwise they become end of life. So I had one spinal cord injury patient who had extensive lower limb injury, pressure injuries, because he's very tall. So the hospital bed was too short for him, and then they put the feet, the heels on some improvised props. So I think they pushed the sofa and then put his heels on the sofa. And then he had pressure injuries in the leg and then necrotizing fasciitis. So he had bilateral upper limb bilateral lower limb above knee amputations because he's still trying to live. And then we figured that actually as a tetraplegic, he's not going to walk anyway. So if we could preserve the health, then he could sit on a wheelchair. But you see the trouble that poor skin care can lead to. All of you are familiar with constipation leading to acute retention of urine. So bowel care also very important, both for the skin and for the urine. And then for respiratory protection, avoid crowded places, receive the necessary vaccination, because any respiratory infections will lead to ICU admissions or death. Okay, so gastrostomies, as you may have heard, would be an important route for nutritional support for MND patients. It is in most of the international neurologic guidelines because the need for nutrition support actually happens quite early. So it is not similar to like ventilation or tracheostomy ventilation or other more extreme life support interventions. Is nasogastric feeding a good route for nutritional support? It may be acceptable if you are not ever planning non-invasive ventilation, because nasogastric tubes do share the upper airway with any mask or nasal interface. And therefore, with if you plan for non-invasive ventilation, nasogastric tubes are a bit of a problem. The other problem with nasogastric tube is that it needs to be changed more frequently. The change often requires the patient to swallow and cooperate, may be possibly more difficult to insert in the MND patient who can't swallow well. And the nasogastric tube world guidelines often require frequent checking of the acidity of the gastric aspirate. Because nasogastric tubes can coil in the throat, the patient may vomit and it can coil in the throat and go down the wrong way, go down the windpipe. And therefore, most nursing guidelines recommend that you check the pH before you feed, and that is very troublesome. So we have had patients who keep coming back to emergency for x-rays because they can't aspirate the gastric fluid, or the gastric fluid is neutral because they are on proton pump inhibitors. And therefore, most of our patients who are open to some degree of life prolongation by nutritional support will get a gastrostomy. It does increase your survival by, I think anecdotally, I think at least a year. I'm not sure what the international latest trials or audits show, but in Singapore, we find that gastrostomy improves survival. It significantly improves quality of life if you're the sort who needs to be energetic and participate in family activities and so on, which any normal person would be. So gastrostomies is something that you will discuss with your MND patients if you are not in a disastrous situation. Like if you're in a war, in a famine, then you may not have resources. But otherwise, this is something that we will be discussing. There are 3 ways to do gastrostomies. So I put radiologic as number 1, endoscopy as number 2, surgical as number 3. So if you remember Dr. John Buck, the US rehab physician who is like the grandfather of chronic ventilation, he actually swears by surgical gastrostomy because in his center there's a surgeon who's very happy to do it under local anesthesia. So what they do is that they just make a cut in the abdomen with local anesthetic, and then they take out the stomach and they put the tube and then they secure it. If your surgeon is very skillful in this procedure, that might be the best and safest. But worldwide, I think most people are looking at endoscopic OGD or radiologic PRG. What is the difference? So I shall discuss the one that requires gastroscopy versus the one that requires X-ray. So the endoscopic way involves first putting the scope in, then at the end of the scope there's a bright light, right? So the bright light can be transluminated through the skin, so you can see the tip of the OGD here. You give local anesthetic, then you puncture and pass a thread, and you grab the thread with the forceps from the OGD. Then they pull the pull the tube, the scope out of the mouth with the string out the mouth. Okay, then to this end of the string, they tie the gastrostomy tube. Then the gastrostomy tube is then pulled back in down into the stomach and pull out through the skin. So they'll widen the puncture to with a blade, with a scalpel, so that they can pull the gastrostomy tube out. So if I describe it in this way, you can imagine the mouth will be open for a large part of the procedure. Therefore, if you are on non-invasive ventilation continuously, is challenging. Can you ventilate someone with a mouth open? Yes, you can try to ventilate with the nasal interface, and you hope that the uvula will go forward and close against the base of tongue so that the air can go into the windpipe, the positive pressure. But bear in mind that from the mouth, we're also putting a large scope, so that is pushing the uvula backwards. And therefore, the tongue seal will not be good. There will be a lot of leak. So if someone is on non-invasive ventilation with the mouth open, the NIV will probably be functioning at 20, 30, or 40% effectiveness. It won't be as good as with the mouth closed. Secondly, the OGD requires carbon dioxide insufflation. So as the scope goes into the oral pharynx, into the esophagus, you need something to open up the passage. So what they do is they actually blow carbon dioxide so that the walls of the esophagus open, the walls of stomach open. What happens to this carbon dioxide? It gets absorbed in the blood. So if you and I go for OGD and if you have real-time pH monitoring, I'm sure we'll all become slightly more acidic. If you monitor our carbon dioxide partial pressure in the tissues or in the exhaled air, it will go up. So in someone with motor neuron disease who's ventilator dependent, plus now with the mouth open, giving carbon dioxide is dangerous. So I would say endoscopic procedure requires intubation or a very well-fitting laryngeal mask. I think intubation is one more secure. Then you can do the OGD, you can do the gastrostomy. So then you will need to extubate the patient after the gastrostomy. So probably if you want to do it endoscopically, you choose a patient with absolutely good vocal cord function, not too severe breathing dysfunction, and a team that is skillful in extubating. So like according to John Buck's protocol, you will need the ICU beds to be available. So in Singapore, in the public hospital, it's so difficult. Maybe in private hospital, you can do that. But private physicians may not be so, have such a high volume of MND patients, may not be so skillful in doing this. The main advantage of an endoscopic approach is that because you pull through, it is actually a tube with a flange. So the flange is very secure. The chance of early dislodgement is low. So that is the main advantage. But I think in MND, the disadvantages outweigh the advantage. Okay, so we do not do a lot of endoscopic gastrostomy. We do a lot of radiologic gastrostomy. So what is the process? If they have a pre-existing nasogastric tube, we use that. If not, the radiologist will put the nasogastric tube into the stomach at the beginning of the procedure. So at the beginning of the procedure, what they do is they ultrasound to map the liver, make sure it's not overlying where they go puncture. Of course, you know the transverse colon is here. So in order not to wrongly puncture the large intestine, we always make sure they are bowel prep the day before they pass motion, clear out the large intestine so that the large intestine is not in the way. Okay, so the radiologist will first ultrasound the liver, mark it off. Then with the nasogastric tube, we pump air. So this time we're not using carbon dioxide, we're using air to distend the stomach. So once the stomach is distended with air, on the X-ray image intensifier, you can see the stomach nicely. Then they find a good spot that is away from the liver, away from the colon. They give local anesthesia infiltration. So give local anesthetic generously. Then they put 3 needles with stitches, we call it gastropexy stitches, to pull the stomach up to the abdominal wall. And then after that, they puncture the stomach with another needle and pass a guide wire through. So this is like setting a central line. And once that is done, the wires in, they dilate the tunnel, and then they put the tube in. So in a pair of good hands, from the first LA infiltration to the end of procedure could be as short as 7 minutes. We usually tell a family 45 minutes so that they don't get too nervous. The advantages of this radiology approach is that you don't need mouth opening. It's very compatible with non-invasive ventilation. So in our center, we don't intubate them at all. We do it with non-invasive ventilation. The tube that is inserted over the guide wire is secured by a balloon. So you inflate the balloon with sterile water. So it means that if you deflate the balloon, you can just pull out the tube. So it's easy to change, and that is helpful if the MND patient is more or less housebound, because then we can do a home visit and change a gastrostomy at home. So that is the advantage of it. The disadvantage is that being a balloon, being held in place by a balloon with sterile water, if someone accidentally deflates the balloon or if the cuff bursts, then you have a risk of dislodgement. We think that the benefits outweigh the risk, so this is the approach we use. So the question is, when should you get a gastrostomy? I think this is what we tell our patients. I'm not sure whether it's not backed up by international literature. It's very anecdotal, but this is what we do in our practice. So if we ask a patient, they notice they are coughing more frequently during meals, they are taking longer with their meals, or they start to have a fear of eating and drinking, they are significantly losing weight, or if the speech therapist assess the swallow and feel that swallow is really at risk. When they have one or more of these, then we think that gastrostomy is essential if you want to live longer, and we strongly advise it. Do we do it earlier? We used to do it earlier. Then we found that patients may end up with unnecessarily early gastrostomy with side effects like granulations, a bit of superficial skin infection or excoriation, and therefore now we tend to do it a bit later. Okay, the guidelines will tell you probably you should do when the forced vital capacity is more than 50%. I think those guidelines may have been informed by people who have a more endoscopic approach. Because endoscopic approach, either you do it nothing and just gastroscopy under local anesthesia with minimal sedation, or you do under general anesthesia. So in both instances, you need adequate breathing capacity. Okay, but in our center, what we have found is that as long as you are able to use non-invasive ventilation, actually, even if your forced vital capacity is quite low, we are confident in helping you get gastrostomy. But if you are severely bowel dysfunction and or bowel dysfunction plus breathing insufficiency, then we often will not do the gastrostomy this way. We will discuss whether you want a trachea, and then we do a gastrostomy after trachea. Or some of them after trachea, they just decide to keep a nasogastric tube, and that's fine. The only disadvantage of trachea plus nasogastric tube, there are two disadvantages. One is if the pH is not good, then they keep coming back to ED for X-ray to confirm nasogastric placement. The second disadvantage of a trachea plus nasogastric tube is that you must manage a trachea cuff pressure properly. Otherwise, you have increased risk of tracheoesophageal fistula. We've seen one case so far. Okay, so I put here one line that says that this may not be an issue in a high volume, highly proficient center. But let's say you are in Star Medical Center and you do gastrostomy once a year, and you have only a visiting respiratory physician who only has like 3 or 5 patients on non-invasive ventilation, and the anesthetist is just maybe a registrar. It would be a bit of a risk trying to do a gastrostomy in such a setting, because you're very likely to cause harm. So I would suggest that for things like gastrostomy, it should be done in a larger volume center, a university medical center, a tertiary big city hospital, and then maybe patients just travel to these centers, get it done safely, and come back home, because you are trying to improve quality of life, and it's not worth the risk of getting it done by amateurs. Okay, some pictures of the gastrostomy. So this is like the tray that is used by the radiology nurse. So you can see this is a dilator. I mean, it's just like preparing to set a central line. In this case, the wire has gone in already, and the radiologist is dilating the hole with the dilator. So by now the patient was quite settled. I was coming down on the sedation, and therefore I could come to the front and take photo. This one I couldn't see very clearly, but I think he's feeding the gastrostomy tube after the dilator is out, if I'm not wrong. Okay, so what is involved in our Tan Tock Seng protocol, getting a patient ready for gastrostomy? We do a pre-anesthetic counseling and review. Usually this happens a few weeks or months before the gastrostomy. So once they start to have fear of eating, they start to cough during meals, the neurologist will refer them to our clinic. And the clinic will often arrange for a non-invasive ventilation trial or acclimatization. Put them on a non-invasive mask with initially CPAP and then transitioning to BiPAP. And we want to see good chest expansion. We auscultate the chest, there's good air entry, auscultate the throat, and you don't hear a lot of throat noises. Why do we do that? Because we want to be sure that we have a backup during the procedure. During the procedure, the first thing is the patient has to lie completely flat because the radiology table cannot be propped up. And if you prop up, there's no space because the X-ray machine will be too near the patient. If you use pillows to prop the fella up, then the X-ray machine is here, the patient's abdomen is here, there's no space to move. So lying flat is challenging for many MND patients. The second reason is when we distend the stomach with air, the diaphragm is splintered even more. So even if they are able to lie flat at rest, when you distend the stomach, they will start to feel uncomfortable. And if they're uncomfortable and they move, then it's risky because they may injure the unintended structures. The third problem is that because they are uncomfortable with the gastric distension, so we sedate them, and then sedation knocks out the breathing. Okay, so NIV trial and acclimatization so that we know that they can tolerate non-invasive ventilation. We may even try to find a good setting. So for example, I know they are good with ST mode 12/5, backup rate 16. Then on the day itself, I go straight to this. I may still have to adjust the setting up or down, but at least I know that 12/5 rate 16 is good for you, at least in the clinic. Okay. Then bowel prep is very important. So we require them to be admitted a night before they get a feed animal or to collect suppository, big bowel movement. Then we do a abdominal X-ray if possible to confirm that the colon is empty. We've been caught out a few times, at least twice, where we actually spent a few weeks worrying about us causing a colocutaneous fistula. That means we worry we puncture the colon and then cause a fistula. Well, if you have a fistula, it's just very ugly. But if you have peritonitis, fecal peritonitis, it's game over for the patient. It's disastrous, right? On the actual day, a home vent anesthetist. So now in my department, there are three of us, myself, Dr. Lim Jia and Dr. Wee Jia. We do home ventilation, home visits. We are all intensivists, so we manage ICU patients. And so we are very familiar with the needs of motor neuron disease patients. On top of that, we are fully qualified anesthetists. So we can provide the anesthesia safely. If an anesthetist has got zero experience with MND patients, he or she may either be overconfident and do things wrong, or maybe overly squeamish and worry and panic too easily. So anesthetists tend to be control freaks. We are obsessive compulsive. So then many of them are very nervous if the oxygen saturation drops below 90. So yeah, so getting someone who is skillful and experienced with non-invasive ventilation, with very familiar with motor neuron disease patient is important. We started out having one home vent nurse to assist the anesthetist and one respiratory therapist to manage a ventilator. Because the anesthetist will often be handling the airway and giving the drug, so I may not be available to change the vent setting. So it's good that I've got someone else to press buttons. But in the absence of our respiratory therapy, sometimes I work with two home vent nurses. So one of the nurses will handle ventilator and one will help me either with charting or with giving of the medications. Throughout the process, I only aim for light sedation. So I tell the patients, I'm not going to make you sleep. You may remember what happened. But my aim is that you got no pain and no anxiety. So this is important because some anesthetists are worried about being sued. You know, intraoperative awareness is unpleasant and some patients are very worried about it. So it's good to talk about it beforehand. You explain to them, oh, you'll be lying there. These are the discomforts you'll feel. There will be a drape. You won't be able to see the procedure is, but you may be able to see the x-ray screen and see your own stomach and everything. We'll be standing behind you. We'll be talking to you. I may be holding your face, holding a mask on your face. So we explain to them that they are not going to be asleep. They're going to be just anxiolized and comfortable. The radiologist will have to give local anesthetic generously so that all their cuts are not painful. I like to use a bit of morphine because when the lignocaine wears off in 1 or 2 hours, I imagine the patient will have some pain. So I usually use a bit of morphine to provide a bit of analgesia into the post-procedure period. And I give paracetamol also. And actually counterintuitively to a lot of people, morphine is has less respiratory depression than fentanyl, because fentanyl is actually a very potent drug. It's just that fentanyl has a high lipid solubility, therefore in low doses it redistributes away. Of course, propofol is very profound in its respiratory depression, and therefore propofol should not be used unless you are trained in anesthesia. So in Singapore, we've had a few plastic surgeons or aesthetic doctors who use propofol when they're doing aesthetic procedures and patients died, and big inquiries. And so now propofol is quite controlled in Singapore. Non-anesthetists cannot use it except in very, very circumscribed situations. Yeah, and then I mentioned using non-invasive ventilation for support as needed. So this is one of our former home van nurses, Lowy. She's holding the mask for the patient. So it's almost like holding an anesthetic mask, but this is a non-invasive ventilator circuit. This is Dr. Sandeep, our procedurist. He's one of our top radiologists doing he's guiding another younger colleague in passing the guide wire. Okay, and you notice this, the image intensifier is very close to the patient. Therefore, getting a patient to sit up on the table is not feasible. Okay, I finished my professional part of the talk. This is something that may or may not be of interest to you. So this is a monthly picnic by our MND warriors. You've noticed that a few of them are actually ventilated and tracheostomized. Some of them are in the early phase of illness and their families. So we are proud to announce that they organized this without informing doctors and nurses. Then subsequently, I was invited as a guest to attend. So I went with a young friend of mine. We are very happy to see that the patients and families are able to look after themselves and advocate for themselves. And we hope that with the MNDA in Singapore and MND beyond borders, we are able to make life somewhat beautiful for MND patients and their families in Indonesia, Malaysia, and Singapore. So with that, I end, and I'm ready to take questions.